Today we're going to be talking about reaching patients with third-party data. I am Rich Briddock, Chief Strategy Officer at Cardinal. I run our media and analytics teams, and I spend a lot of time trying to work with different data partners and vendors to find new ways to reach the right patient at the right time throughout the funnel. So got a lot of ground to cover today. I'm gonna jump right in and talk about what we're going to cover in the agenda. So firstly, we'll talk a little bit about the problem statement. How do we reach the right audiences? Then we're going to talk about some of the third-party audience solutions that help us to solve this. We'll get into some of the nitty-gritty with real-world execution, and then we'll walk through whether or not third-party audiences are right for you, or when and where you should deploy them by using a simple decisioning framework. And after that, if there's time, we'll do questions, but I think this is going to be a pretty packed session today, so we may not get to too many questions. And you can always follow up with me after the session if you have any questions, and I can address them then. So let's jump in. We, as marketers, we're always aware of some of the challenges in healthcare of reaching the right audiences, and oftentimes this is highlighted by the gaps in native audience targeting. We've seen shifts with Google not allowing first-party data for a long time. Meta has been on this trajectory of reducing the types of targeting that you can do within Meta, and also shifting towards Advantage Plus, where it takes that targeting option out of your control. And there's a lot of advantages to that, but when you're trying to reach a really specific and niche audience, and specifically if you're unable to pass a qualified signal back into Meta, that creates challenges if you just don't have those controls as to who you're able to target. So this is becoming more and more of a challenge as privacy frameworks continue to evolve, and we move more towards a world that's driven by AI targeting, broad targeting, and that lack of the ability to reach specific audiences. So the good news is, there are some options out there, but let's start by talking about a pretty seismic update that's just happened in the meta world that really underlines the trend that I was just talking about on the last slide. I'm sure you guys, if you read marketing blogs and websites, you've probably heard a lot about Andromeda recently. This is where Meta is saying, we'll handle the targeting, you just give us the creative, we're going to help, with Advantage Plus, we're going to find the right people for you. And really it's about, what they're looking for is a very simplified, Meta's looking for a very simplified structure, very broad audiences, and your job is really just to give them the different creative to test, as well as different landing page experiences that they can test as well. Like I said, this is a great solution and can be highly effective if you're able to pass the right signals back into Meta. But with some of the updates like around healthcare and sensitive categories that happened in January, it's becoming more and more difficult to pass those right signals into the platform. And so we kind of want to buck this trend a little bit and actually get really specific about the types of folks that we want to target, the types of prospective patients that we want to reach. And so on this slide, we'll really dig into that and highlight some of the challenges of using native targeting and just relying on an algorithm to find the right folks. So in this scenario, we have 3 prospects. They are specifically the same demographic profile. It's a woman age 35 to 44. They're all showing interest in behavioral health services, but what's crucial is they have varying healthcare needs, and they have different insurance coverage and they're different reimbursements. And so you've got prospect A, they need therapy, but they're covered by Medicaid. You are a behavioral health client that does not accept Medicaid. So for you, unless that person is going to pay cash pay, they are likely not a prospect. Prospect B, they need therapy and they're covered by Cigna. So great, they are a prospect. And then prospect C, they need medication management and therapy and they're covered by Aetna, also a prospect. And actually from a revenue point of view, from the things that drive the business forward, they're actually the best possible prospect. They have a higher lifetime value than prospect B. And obviously they have a much higher lifetime value than prospect A, who is not a prospect. But to the platform, all 3 of these folks look exactly the same. They all have the same demographic, they have the same interests, they're showing the same behavior online. So it's very difficult for an algorithm to determine that prospect C is the winner, prospect A is not what we want to optimize to. And so we're going to talk through a little bit of a few tactics here about how you can reach more of prospect C and less of prospect A and make your marketing budget go much further. So before we get into all the third-party options out there, I think it's important to touch firstly on a specific differentiation in terms of types of audiences. There are both deterministic audiences and probabilistic or modeled audiences. And the difference between the two is, if you're not familiar with this approach, is a deterministic audience is someone who has the identifier or fits into the audience that you are trying to target, i.e., they have been diagnosed with this condition, or they have had this procedure, or they are taking this medication. Whereas a probabilistic audience is someone who is likely to have that condition, or likely to have had that procedure, or be in market for that procedure, or likely to take that medication or need to take that medication. And those probabilistic or modeled audiences are inferred from a seed list, from a core of a deterministic audience. So deterministic are true of like the sort of the middle of the bullseye in terms of reaching people with a certain condition or reaching someone who has had a certain procedure. Probabilistic is more of a scaled audience based on that group inside of the bullseye, both so that you can reach more folks further up the funnel, but also, so you can essentially scale your audience and reach people who are still highly likely to be interested. If you're targeting, if your deterministic audience is quite small and makes it difficult to scale. So I mentioned some of these already, but some of the targeting options that exist through third-party audiences, there is that clinical component that I was talking about. So I've had a diagnosis, or I've had a certain procedure, or I'm taking a certain medication. There's also a couple of other targeting options that I think are really important. Payer mix. So do I have the right insurance coverage? And that can go from a broader bucket of commercially insured versus Medicaid, or you can get right down to the specific payer if you're looking for folks who have Aetna versus folks who have Cigna. And this is really important when you start to think about your payer strategy, your reimbursement rates. Maybe you have different reimbursement rates by state. If you're in multiple states, you want to reach an Aetna audience in New Jersey, but you really want to reach a Cigna audience in Illinois. And of course, you may have different payer contracts as well, which means you are in network with some payers in certain states, but not others. So this is a really nice targeting feature that allows you to be very nuanced from a geographical perspective in terms of, just modifying that audience based on where you're serving your advertising. And then the other one that's big and oftentimes gets overlooked is social determinants of health. So other tangential things that might increase the likelihood that you'll need a service or need a certain provider, lifestyle stuff, behavioral stuff, but then also how a user likes to interact with a healthcare provider. So we can target users, we have a virtual addiction client that we work with. We can target users who like to consume their healthcare through telemedicine, as an example. You probably would exclude folks who want to consume healthcare in person. If you're a virtual provider, that wouldn't make sense. So we can get very, very specific about the types of targeting that we offer to make sure that we are engaging with that perfect user. So just going back to the example that we showed, third-party audience targeting is going to allow us to get to prospect C because we're building an audience that is targeting Aetna. We're using claims data that shows that this user has both been diagnosed with depression and anxiety, and that they're being prescribed medication in addition to therapy services, pulling from this claims data. So we know that that is our highest value target if we want to reach an audience of both of users who is going to be looking for med management and therapy services, we can literally create that audience based on, you know, the claims data and these other attributes. And like I said, you know, if you're a virtual provider, you could even be layering in health behaviors in terms of, I like to consume my healthcare through telemedicine, just to dial that audience in even further, and find the right prospect that, you know, will where you will be able to differentiate yourself and meet their needs. So I've kind of touched on this a little bit as well. You know, deterministic audiences, that was, you know, if we go back to C, that last slide, this is all done through a deterministic audience strategy. You know, we know that this user has these attributes. We know that they have this condition. We know that they've, you know, that they have this payer. But why would you use a modeled audience instead of deterministic audiences? Deterministic audiences sounds fantastic. Why would you use a model audience? Well, I mentioned one before, it's scaling, you know, especially if you have a relatively niche audience that you're trying to reach. You don't want to just hit 100 people 7 times a day. You want to go look for users beyond that. And oftentimes scaling can double, sometimes even triple your audience when you're using a modeled audience versus a deterministic audience. So that gives you, you know, the right size of audience to really optimize against. The other key point though is timing. So oftentimes when a user falls into a deterministic bucket, it might be too late when you're seeing that user in the claims data. They may have already, you know, if they've been diagnosed with a certain condition, you see them in the claims data 2-3 weeks later, they may have already sought out treatment, depending on how acute the need is for that specific audience. They may have already gone and found a provider, and therefore you're chasing folks who are already out of the market in terms of the healthcare solutions that you offer. So sometimes it can actually be better to target a modeled audience built off a seed list of people who are showing a lot of the same behaviors and have a lot of the same attributes as those folks in the deterministic audience, but they might be slightly further up the funnel. They haven't had that initial diagnosis yet, or they haven't had that initial procedure yet. So there's still time to engage with them and start to educate them and nurture them and differentiate your brand from a competitive set before they, you know, make their healthcare selection decision. So that's another great reason why modeled audiences can be highly valuable when used in conjunction with deterministic audiences. This is this just really illustrates the sort of timing piece. So when we use modeled audiences, it's a decile-based approach. So we're looking at the entire population and we're saying, okay, of the entire population inside a geo, if you are a 1 out of 10, you are least likely to have that condition, or, you know, to have that insurance, or whatever the attribute is, you are least likely. If you are a 10, you are most likely, which almost certainly means you have it. It almost certainly means you would actually fall into the deterministic bucket as well. Now, oftentimes when we're looking at deciles, similar to the point on scale and timing, we're targeting 8, 9s, and 10s, but we often see the most success with 9s because, again, they're very likely to have that condition or to need that treatment, but they may not have appeared in the claims data yet. They may not have actually taken the action. So oftentimes when we're thinking about a decile-based modeled audience, 9 is actually the sweet spot, not 10. And oftentimes 9 generally tends to be a larger decile anyway. So it gives us a bit more scale to go chase than trying to reach the 10s. So again, I know I'm covering a lot in a very short period of time, but just think when you're thinking about third-party audiences and you're thinking about, should I use deterministic or should I use probabilistic, I would recommend that you use a mixture of both to really find out what works and how you can engage at different parts of the funnel. It's also important to think that potentially a modeled audience might be better in the middle of the funnel or even at the top of the funnel, whereas a deterministic audience could be more useful at the bottom of the funnel because these people are closer to conversion. So another thing that is really important in third-party audiences is sometimes you have to reach a decision maker that is not the patient. And that's very difficult to do with claims data, specifically around pediatrics. So we work in the ABA therapy space. We work with children's hospitals. We do a lot with pediatrics, and you cannot target children. It's probably self-explanatory based on claims data. You cannot target children with advertising. So how do you reach the patient? Because the parent, because they don't appear in that claims data. So we have some contextual audience providers that we use that really help us to reach the right households versus the right patient. And so if you fall in the pediatric space, the good news is there are third-party audience solutions that will essentially allow you to supercharge your contextual targeting strategy to reach mom and dad. Oh, hang on a second. There's a beverage. There's a beverage that's arrived for me. Nothing says third-party audiences like a beer. So reach those, the right contextual audience, despite the fact that they might be a sensitive category like pediatrics. You can still reach the parents. So again, if you want more detail on this, we can, you feel free to reach out to me on LinkedIn and we can discuss some of the options. But know that there are solutions out there if you are in a category like this. It's not just targeting is not just the only solution here, it's also exclusion. So again, talking about that timeline of potentially like diagnosis to care, or noticing of symptoms to care, that patient journey, exclusions can be really important. If you have a deterministic audience that shows that someone in the last month or the last 3 months has received treatment for something that you do, use that claims data, use that deterministic audience as an exclusion strategy, right? You probably don't want to reach folks who have, if you are BetterHelp, you probably don't want to reach folks who've just recently got treatment with Talkspace, for instance. So you can exclude those folks if they've just sought treatment within the last 30 days, within the last 60 days, so that you're not spending budget against that, those folks who probably aren't in market anymore. And that, this is a great way to avoid wasting budget on patients where you've just missed them. It's just too late. It doesn't mean that you can't re-engage them later, but it really helps you to focus the dollars, especially if they're finite, on those folks that are truly in market, that haven't taken the action yet, and that are still looking for that healthcare provider. All right, so let's talk about some examples to try and really bring this to life. We're talking about concepts, but I think examples really help. So this was a fun one. We have a mammography client, and we built an audience targeting women 35 to 55, where they'd either had no prior mammogram screenings, or they were what we call lap screeners. So they hadn't had a screening in 2+ years, but they had had a screening at some point. And so using claims, we were able to target an audience that had, we were able to exclude women in that demographic that had had a prior mammogram within the last 2 years. So this is really an exclusion strategy, and then target the right payer mix that our client was in network with. And then we could even exclude different specific zips where we knew that were heavily in Medicaid. And then we were using psychographic data to really help understand how we were to talk to these folks and really create a message that would resonate with them and differentiate our client from some of the other options offering mammograms that those users could choose. And so this gave us the sort of information to speak to convenience, speak to relief, speak to proactive health, as well as to address some of the barriers in terms of, you're too busy. How do I don't have time for this. I'm a busy mom. I've got a family. I'm the breadwinner, et cetera, et cetera. So really it gave us the information to break down those barriers, and also to test different messaging against different audience segments that we were running for this client. And what we saw was click-through rates went through the roof. We were targeting a much more qualified audience. We were using the psychographic information to really hone the message as well. That helped drive down our cost per clicks and ultimately drive down our cost per acquisition. And the client was very happy with this. So great results from using third-party audiences when compared to the native off-the-shelf options that were also available to us. Another success story, and I sort of mentioned this client earlier on in the presentation, but we were using native meta audiences to target for a virtual addiction service client. We were getting a ton of leads, but they were pretty low quality. There was just no flow through from the lead to, some of the more deeper qualified signals that drive revenue for that client. And it got to the point where the client was saying to us, this doesn't work for us. We want to turn this off. So we started using these claim-based segment audiences. We used a modeled audience based on users who most likely need addiction services. We added the payer layer because that's so important in addiction. There's a lot of these groups are do not accept Medicaid. So we added in the payer coverage layer. And then we added in that health behavior that I was discussing earlier of users who are much more likely to leverage telemedicine than to leverage in-person medicine. And we actually excluded people who want to consume medicine in office, in person, just to make sure that we weren't reaching people who were looking for in-person addiction services. Again, we saw great results. Our click-through rate went up 34%, CPCs down 16%. And because we were reaching so much more of a qualified audience, our acquisition costs fell by 25%. And I think something else that's important here is you are paying for these audiences. So there is a data fee that you have to pay to use these audiences, but hopefully they are that much more qualified than the native audiences that you can tap into, that you still see efficiency gains in both your cost per click, but more importantly in your cost per action in terms of your cost per lead. Okay, so I know we're in a sort of final 9 minutes here. We're going to talk a little bit about the decision framework and whether or not third-party audience activation is right for you and really when you should consider it. So strong candidates for 3P investment. Like I said, you are paying for this. You have to have a relationship with these third-party providers, or you have to work with an agency like ours that has a relationship with these third-party providers. But it's great if your bottom of the funnel campaigns are maxed out, right? So, most healthcare clients, they're going to start with search. That's where they're going to focus their efforts. They're going to start with demand capture, strong SEO programs, strong paid search programs that some of these other sessions have covered. But once you've exhausted that, once you've really started to hit diminishing returns there, you've got to go up the funnel and you've got to engage through demand generation tactics and start to meet the audience where they are. And that might not necessarily be on the search engine results page. So it's a great tactic for people who are saturated on search. It's also great if payer mix is a crucial element in whether or not a patient is qualified or not, or a patient prospect is qualified or not for you. If you have specialized services with narrow patient population, high acuity, high LTV, that you need to have different stages of the funnel and you need to serve them different messaging. I think it's also a fantastic option for candidates where you need to do a lot of emotive messaging. You need to really serve them video. You need to engage at multiple touch points across the funnel. And you can't just rely on capturing that engagement at the bottom of the funnel and converting. That's another fantastic candidate. In terms of budget, probably for advertisers who spend at least $30,000 a month or more on media, you probably wouldn't be diversifying into this strategy if you weren't. When to wait, it's kind of the opposite of when to go. But I think, obviously if you're very low acuity, you can convert at the bottom of the funnel. You're nowhere near saturation on search. If you don't have an effective way to measure demand generation and understand its impact on the business, these are all reasons to pause and really get these elements in place before you move into third-party audiences and into a lot of demand generation efforts. That being said, it's still important to do these things because, again, you might start scaling the business, hopefully, and you may hit that point of diminishing return where third-party data really makes sense for you. I touched on a lot of this already, but again, I think probably a lot of you, if you're doing social right now, in particular, and typically with healthcare, we see folks are doing more social than they are programmatic. So that's why we're using this comparison. But if you are on Meta and you're using Advantage Plus right now, like I said, it's great for broad awareness. It's great. It's very low effort. The algorithm does everything for you. There's no cost. But the issue is the zero transparency. All you know is that Advantage Plus works when you pair it with this creative and this landing page. But that's it. You don't know what inside of that audience is working. It's very difficult to understand audience insights except from the types of leads that you're getting through. And by that point, you've already paid for that lead. So if the leads that are coming through are low quality, there's not really any dials that you can, tweak to try and improve the quality, except change the creative all the time. And again, that becomes tricky. We worked with folks, again, I'm just going to use the behavioral health space as an example, where all their creative on Meta just had to be insurance logos that they accept. Because what was happening is Meta was just driving a ton of leads where they were Medicaid or they didn't have the right insurance, they weren't in network, and that was just crushing their performance on Meta. And so their creative strategy just became, how many insurance logos can we put on an ad? Well, that's not a great user experience. It might help lead quality, but it doesn't really help your brand resonate with prospective patients. So by using third-party data audiences, you can circumnavigate that issue, and then you can get back to really understanding the demographic, really understanding the patient, and putting forward user-centric messaging that really resonates with them, rather than having to focus all your creative on trying to pre-qualify your audience because your audience is not already qualified. All right, so the way that we like to think about this in terms of, again, should I do 3P audiences and does it work for me, is thinking about the cost-benefit analysis framework. So your total cost formula is going to be your media spend. That's the money that you're pushing through Meta or the money that you're pushing through programmatic, plus your third-party data CPM that you're going to pay to one of these third-party providers. And then really what you're thinking about is from there, does my patient CAC, did it fall more than what I had to invest in these third-party audiences? Am I seeing a higher rate of return on these third-party audiences than the expenditure that I'm having to give to these different companies to build and run these audiences in the first place? And I think some of the metrics you guys will already be familiar with. I'm not going to go through them all, but thinking about things like ROAS, thinking about things like incrementality specifically, like, are we reaching a new set of patients that we weren't engaging or converting through native targeting? That's a huge one. But most of the other KPIs are things that you guys will be familiar with when you're assessing this tactic and whether it's working. So how should you think about deploying third-party audiences? Well, other than finding a third-party audience provider that can give you the audience, and there, by the way, there are plenty out there, and we can touch on some of those here in a second. Then you've got to think about, am I just going to launch this across every geo, every tactic, or am I going to be smart in the way that I deploy this? Ideally, what you're doing is you're doing what we would call a geo lift experiment. So you're running these audiences in some markets, but you're not running them in others. And what that's going to help tell you is it's going to help you isolate the impact of third-party audiences in your targeting mix, because we all know that the patient journey is complicated, and we all know that Meta doesn't always get direct attribution, or programmatic doesn't get direct attribution. There's very finite look-back windows. That's if you can even track things through Meta. So the better way to do it is to deploy these audiences in a specific geographic area, and then see, do my leads, do my new patients, do my bookings, etc., do they grow once I deploy those third-party audiences in that geo versus the control? Like, is there a halo effect that I see across the entire lead generation and new patient marketing machine by deploying these third-party audiences? That is the better way to approach this than just thinking through the lens of direct attribution, which, by the way, may also improve, but you want to be more holistic than that. Okay, I'm probably not going to go through all of these slides because there's just a ton of information on this, but I think the sort of key piece is you should have a testing roadmap when you're deploying third-party audiences, just like you should have a testing roadmap when you're doing anything else through digital marketing. And you should be okay with failing fast, right? If you don't see an improvement in cost per booking or in the KPI that you're looking for, quickly reassess that after 60 days. These third-party audiences are going to take some time to bake in. They're not going to work day one, week one. They will require, there's a learning phase. The algorithm has to adjust. But if you're not seeing anything, if you're not seeing an uptick in 60 days, reassess. Think about going from a deterministic audience to a modeled audience. Think about changing some of the parameters of your audience, but just be agile and nimble so that you can get to the right solution without blowing through too much budget. some of the vendor landscapes, I know we're basically at time, so I'll go really quick on this. Deterministic claims data, there's a couple that we use. Purple Labs, the solution built in for that already. Common mistakes, I think this again, this is pretty general, but don't jump in unless you can really measure. So again, going back to that halo, that more holistic measurement strategy. Don't use generic creative. You're really honing in who you're talking to. So make sure that your messaging also speaks specifically to that user. Don't act too quickly. So don't ignore that there's a data lag. Sometimes claims data can be a couple of weeks old. Patient may have already selected the provider. So make sure that you're using the right exclusions, and make sure try and pick up on signals that may happen earlier in the patient journey that could be valuable to build audiences from. You might not want to target a procedure, you might want to target a diagnosis, or you may even want to target medication that happens prior to a procedure. Those are the pieces that you'll have to figure out. And then, not expecting immediate results is another obvious one, and not layering in too many signals so that you make your audiences too small, you don't have the scale, and then you just end up with a bunch of frequency and poor performance. All right. Well, like I promised, I knew we weren't going to get to questions, but I hope that you guys found this session useful. Thanks for joining me today. And we hope that you've had a great time in scaling up. Thank you very much. Goodbye.